physical, mental, and social conditions. So you can see the holistic approach of cardiac rehabilitation, so that patients with chronic or post-acute cardiovascular disease may, by their own efforts, preserve or resume their proper place in society and lead an active life. You can see society here, you can see active life, you can see perhaps from now that cardiac rehabilitation is not just about treating heart disease with drugs or with exercise. It's much more than that. It's a holistic approach which covers almost every aspect of life. So is there evidence for cardiac rehabilitation? I'm sure you have seen this table many times. These are the classes and these are the levels of evidence. The classes benefit towards risk. The level of evidence is the quality of research backing it. So cardiac rehab is a class A, level A recommendation for almost all patients with heart disease, as we will see ahead. I am putting throughout this presentation the European and the British guidelines for cardiac rehabilitation. The American, the Canadian, the Australian guidelines are almost similar with the European and the British, so I'm just using them just out of convenience. So what is cardiac rehabilitation? It is a structured program of care, which means that it has a specific duration, it has specific components, and it has specific people who deliver these components. That consists of medication, exercise, and lifestyle changes that are promoted through education and counseling. So this is rather old photo of an exercise session. I put it here again because I like how it started. You will see another photo in this presentation of our gym. Our gym is consisted of stations in which patients pass from one station to the next and they stay for a few minutes in each station. This is called circuit program, which improves the adherence to exercise because it's much more interesting for the patient and interactive with the patients. But this photo, as you can see here, is a good aerobic exercise on the bicycle or the treadmill ergometer. So I mentioned a structured program of care, which means that it has specific components, duration, and staff. So we have a multidisciplinary team in cardiac rehabilitation. We have cardiologist, exercise physiologist, nurse, physiotherapist, dietitian, occupational therapist, pharmacist, of course. We have many people working together, trying to provide a holistic therapy and rehabilitation to the patients. So cardiac rehabilitation has phases, and the phases depend on the area of the world that we're at. The phase 1 is the inpatient cardiac rehabilitation. I will not talk about that today. This is a brief phase in which patients in the hospital receive mainly education about the risk factor of the disease and other things. I'm interested today to talk about phase 3 in Europe, or phase 2 here. This is phase 2 here. This is the phase that the patients are invited to join an outpatient program. And this is what I'm going to present today. And then we have the last phase, which is the phase after the program that we offer, which is also called community-based rehabilitation. This is the maintenance of the healthy lifestyle. In Qatar, we have some bonds with the Qatar Diabetes Association. So all our patients who are discharged from phase 2, they receive a referral if they are diabetic to Qatar Diabetes Association, and they continue their community-based rehabilitation there. So which patients are eligible for cardiac rehabilitation? Well, almost always and all the patients. Patients with stable angina, acute coronary syndrome, patients who have done PCI or CABG, heart valve repair or replacement, transplantation, not yet in Qatar, but they are eligible, and even patients with heart failure, excluding NIHA4, excluding symptoms at rest. So as you can see here, most patients can and should participate in cardiac rehabilitation. So what does it consist of? Cardiac rehabilitation has these core components, as we say. First of all, we have the patient assessment, which is initial, before the patient is enrolled in the program, and final, when the patient finishes the program, to see what we achieved. And sometimes, of course, if we need to reassess the patient during the program, we have reassessments during the program. Then the patient is enrolled in the program that I will explain in a while. And the program has nutritional counseling from the dietitian, weight management from the dietitian, in collaboration with the physiotherapist or the exercise physiologist, and perhaps the pharmacist. Blood pressure management, again, the team is working together. The cardiologist with the pharmacist are there for the medication, the exercise physiologist or physio for the exercise, and the dietitian for the diet. Lipid management, again, the same people. Smoking cessation, here we have our occupational therapists who are helping the patient stop smoking if required through counseling. Psychosocial management, which is very important. I'm not sure if you are aware, but that 1 in 5 patients with heart disease have significantly elevated depressive symptoms, but this probably is not shown because many patients, they just conceal it or they don't want to admit it. So this goes unobserved, and it may cause a serious worsening in prognosis of the heart disease. So we screen all these patients in the heart hospital for depression, as it is suggested by major organizations like the American Heart Association. We also have physical activity counseling, which is very easy, but very hard to do. As you can see with most of us, I'm not sure how many of us here are sufficiently physically active. We'll see about that. We have the exercise training, which is the 3 times per week of exercise that we offer for a specific period of time, usually 3 months. And then we have the results, as I said, in the assessment, the results evaluation to see what we achieved there, what went well, what we did not achieve, how many goals we met, and the follow-up with the patient. So let's go through very, very briefly, perhaps, each one of these core components, and then we can talk about COVID. So the patient assessment, of course, has the clinical history. Why did this patient come to us? Is there a myocardial infarction there? Is there heart failure? Was there any investigation? Was there any procedure there? Does the patient have any signs or symptoms? Does it have any angina? Does it have any other symptoms like fatigue or breathlessness on exertion? So we have the physical examination, which is conducted by the physician, of course, the cardiologist, to see if there are any murmurs, for example, auscultation and other physical examination that he's performing. Physical examination is also conducted by the physiotherapist to see any musculoskeletal problems, because these patients are going to enroll in exercise. So we need to make sure that exercise is safe for them. Then we have the 12-lead ECG and cardiac imaging wherever available. We can see any reports about ejection fraction, for example, or the valves condition in the heart. Then we have the blood tests, which are very important to see the lipid levels in the body, the blood sugar in the body, because all these things have to be controlled. Then we ask about the physical activity level, which has lately been introduced, or if you want, suggested to be one of the vital signs. This is a new initiative from the American College of Sports Medicine. Like we take the blood pressure and the heart rate, we should also take the physical activity level, because physical activity is very, very tightly related to mortality. Then we have the frailty level. This is a new recommendation after COVID. Usually, or ideally, it should be done in every patient who is elderly, more than 65 years old. But also, it should be considered for every patient. And of course, we have the symptom-limited exercise test, which is a test up to exertion. This is a test either on a cycloergometer, as we can see here, or on a treadmill, when the patient is required to cycle or walk in an increasing speed and inclination on the treadmill until he cannot do more, until they reach their maximal exertion. This is a very important test because it allows us to see the limits of the patients Perhaps some patients may have angina, so we can see the ischemic threshold of these patients. Some patients may show changes in their ECG, arrhythmias, or ST depression. So we can see at which level of heart rate these changes appear. So we can keep the exercise below that heart rate to protect them. And of course, we can determine the maximal heart rate, the true maximal heart rate from which we can generate the energy exercise prescription for the patient, which will be the exact, efficient, and effective training zone for each patient. After we do all these things, we have the risk stratification, which is the allocation of the patients in one of these three risk categories, which is low, intermediate, and high risk. This is conducted through a system of putting all the variables that are important there. This is very important for us because, first of all, it shows the prognosis of the patient. And second, it shows the level of monitoring of the patients when we do exercise. A low-risk patient doesn't need to have very thorough and consistent monitoring. On the contrary, a high-risk patient needs to be carefully monitored during exercise and for more sessions than the low-risk patient. So then we go to nutritional counseling, which is done by our favorite dietitians. The dietitians assess the daily caloric intake of the patients. If the patients are obese, for example, or overweight, they need to reduce the intake of calories. If they are underweight, they are advised to increase them. The patients are educated themselves, but also family members are educated. The wife, the husband, for example, or the parents of the patient, because they are also involved in the food preparation, perhaps, or the habits of eating outside or inside the house. So they also need to know these things. One of the diets that we prescribe is the Mediterranean diet, as you can see here, which is a diet rich in fruits and vegetables and legumes and fish, as you can see, olive oil and nuts. Not so much meat there, not any processed food. The diet, of course, should be tailor-made. Each patient has their own background. Each country has their own diet habits, so we need to adjust the diet into the background of every patient. But some things are common for everyone. For example, we should not drink sugar-sweetened drinks. That's a big no here. And we should not take trans fatty acids. It's again a big no. Just a few recommendations here. I'm not going to in detail on that. I'm not a dietitian either. But I want to show you the main things that we're doing.
Dr. Ted?
Yes.
Just before we proceed, I have here a question regarding the frailty test and its significance in terms of cardiac rehab. So what you do exactly and why?
So the frailty test is a rather new recommendation from mainly the European Society of Cardiology. There has been some studies lately about frailty, that it may be a risk factor for worsening of heart disease, and especially when the patients are enrolled in an exercise program. The balance of the patient needs to be monitored very carefully. So, and also the level of exercise impact on the joints needs to be monitored very carefully.
Okay.
The elderly patients have a higher risk of fall, and if these patients have osteoporosis, or if they are prone to osteoporosis, then also we should take this under consideration for the impact exercises there.
Yeah, interesting.
So ideally, this should be done in every patient more than 65 years old.
Okay, interesting. And when you say high risk versus low risk patients, are you referring to cardiovascular disease or any like other comorbidities?
Yes, the risk is a combination of cardiac and metabolic risk.
Okay.
So it takes considerations from the cardiac perspective, like ejection fraction, the results of the exercise test, the cardiorespiratory fitness, and then we take the consideration from the metabolic side, which is the presence of diabetes, obesity, the dyslipidemia profile. So we combine all these factors together to generate the the overall risk, which is the cardiac risk.
Sure, yeah. We have a question here also from the audience, how we can know the risk if it's low or high as a normal people. I think maybe we have like a cardiovascular risk calculation here. It's not the same way we classify patients with cardiovascular disease, right?
Yeah, there are many models that can predict the risk for patients with heart disease. We just have an amalgamation of the Framingham model with the Canadian model of cardiac rehabilitation and the American. We see it more holistic there because it also includes other factors, including depression, for example. So in order to have a good risk, you need to do the examinations that are required, for example, the blood tests or the exercise tests. This will help you have a more, if you want, a comprehensive calculation of your overall risk.
Yeah, exactly. And they need to do like a lipid profile, the blood pressure. Yes, yeah, I do agree.
Certainly.
Okay, thank you. Thank you.
Yeah. So we can move on in the weight management here. Again, we assess the weight, height, waist, caloric intake, and physical activity. All these factors need to be combined and taken into consideration. So if the patient, as I said, is overweight or obese, we should aim for a lower caloric intake and an increased level of physical activity. Physical activity is always good to be increased, even in underweight patients. So even if the patient is underweight, they should not stop their physical activity, of course, but they should increase their caloric intake. And the dietitian there plays a very important role. We have behavioral and nutritional counseling. Our jobs is changing behavior in general, more than less. So there are many behavioral models that we can deploy to change behaviors. So one of them is the trans-theoretical model of change that we are applying in the heart hospital, but there are other models as well. But it's my recommendation and the guidelines recommendation that any counseling regarding behavioral change, whether this is weight reduction or smoking cessation, should be done in an integrative way and consistent way, to have a model there, to have a specific things to say at each stage, and not just have a chat with the patient and try to convince the patient out of your own mind or whatever you want. So we try to apply a systematic approach here. We apply the trans-theoretical model of change, and we aim to reduce the weight in obese patients 5 to 10%. And if the patient is overweight, we consider reducing the weight 5 to 10%. This, of course, is done in collaboration with the patient. If the patient is not willing to change, there are things to do there, but there's no point in counseling the patient about weight change if the patient doesn't want to do that. So we move on to blood pressure management. As you can see, these things here require the presence of the patients there in the hospital. So during COVID, you can imagine how these things have been distorted. So this is the photo of the American Heart Association page about the blood pressure. You can see happy people there doing physical activity, which is very important for blood pressure. So if the systolic blood pressure is between 120 to 129 and the diastolic, this has to be both, is less than 80, then only lifestyle modifications like this physical activity that we saw here, the DASH diet, perhaps a diet which is rich in vegetables and fruits and less salt, of course. But if the blood pressure is higher, then things get tricky. So we have the blood pressure now 130 to 139, or the diastolic 80 to 29. Then we should add medication in very high-risk patients. I put a very high-risk patient there in asterisks because there is a difference in the definition of very high-risk patient between the European and the American guidelines. But in general, if the patient has atherosclerotic disease, which is the vast majority of our patients, then these patients are considered very high-risk patients, especially if they also had an event. That's why they came to us. So this applies to almost all the patients that we have. If the patient is more than 100 systolic or more than 90 or equal diastolic, then for sure we need to have both lifestyle modifications and drug treatment. The general target is less than 140 to 90. This is the general for the whole population. If the patients are less than 65 years old and they can tolerate it, it should be less than 130 to 80. And in all patients who have hypertension and are taking drugs, the aim is the diastolic to be less than 80 milligram of mercury. So this is an aggressive approach, of course, but it is mandatory. We all know that hypertension is the #1 silent killer in the world. We never realize it, but then it happens, and sometimes it's too late. So we need to tackle it very aggressively.
Dr. Ted,
Yes.
sorry, if you may allow me to go back to the behavioral changes.
Yes.
So we have a question, when it comes to smoking, diet, alcohol consumption, maybe I will add to this medication and adherence. Do you prioritize which behavior you have to change, or you have to tackle all of them?
All of them. We don't prioritize. We have a
Okay.
holistic approach, which means every core component needs to be addressed.
Interesting.
Every core component is equally important, and we have staff and specialties that are involved for every core component. If you also tackle one core component specifically and let the others without any management, then the result will not be good at all. Because as we know, our life is not just eating, or it's not just smoking, or not
Yes.
just walking. We do all these things together. So we need to approach everyone in a holistic way.
Yeah, it's interesting to see actually this program that provides, everything at the same time, which is actually extraordinary. Yeah, thank you.
Yeah, thanks, Mona.
Thank you.
Let's move on to the lipid management now. I think we're good in time, very well. So for the lipids, we have diet, we have physical activity, and we have medication. All these three factors are very important. All these three factors help to balance the lipid profile of our body. So in patients with atherosclerosis, which are very high-risk patients, as we mentioned before, the aim is to reduce LDL more than 50% or equal from baseline, and to be less than 1.4 millimole per liters. Both of them need to apply. And in case of patients having a second vascular event within 2 years, which are some patients that we see, then we need to be even more aggressive to reduce the LDL to less than 1 millimole per liter. So again, you can see the team there involved: the dietitian, the physiotherapist, the exercise physiologist, the pharmacist, the cardiologist. All these people are working together. There are team conferences, weekly team conferences that we have in the heart hospital, in which we go through every one patient that we have enrolled in the program, and we check all these things for every patient, and all these people are there. The cardiologist is there, the pharmacist, all these people, all the disciplines are there. So every patient is discussed with all the disciplines present. This is very important, because otherwise we cannot work and we cannot collaborate very well. If the people don't meet and they don't interact to see how they work together, it's very difficult to tackle all these risk factors at the same time. Then we go to smoking cessation, which is very easy to say. It is necessary, of course, but not always attainable. Smoking is addictive. It's not easy to stop it. That's why we educate the patients, we counsel the patients. One of the counseling tools that we have is the motivational interviewing. This is a tool in which we try to show the contradiction, the discrepancy between the goals that the patient have. For example, a grandfather would like to play with their grandchildren in the garden, but then when he tries to play, he has breathlessness because he is smoking. So this is the goal that this patient has, to play and have fun with his grandchildren, And on the other hand, he has this tendency to smoke. So we tend to show the patient this discrepancy between their goals and reality. And we need to motivate these patients to see this discrepancy and try to want intrinsically to change this discrepancy and overwhelm it. It's not easy, of course. It's not applicable for every patient. It's not applicable for every stage of change for every patient. For example, if the patient doesn't want to hear about smoking cessation, it's pointless to talk about motivational interviewing. But if the patient leaves the window a little bit open, then you can go there and you can show him the discrepancy. You can achieve things there. Our pharmacists, of course, are very active here because they can help the patient with either nicotine replacement or bupropion and varenicline. So at the moment, we're trying to have a smoking cessation clinic in the Heart Hospital, but there is a good smoking cessation clinic in the Hammer General Hospital in which we refer our patients, but we are going to have our own clinic as well in the Heart Hospital soon, inshallah.
Dr. Ted?
Yes.
If I may ask you regarding the previous point when you talked about the lipid management. So I noticed that these were very stringent kind of targets. I was wondering, are these targets from the European guidelines? And can you comment on the difference between the European guidelines and the American guidelines in that perspective?
Certainly. Yes, these are the guidelines from the European Society of Cardiology, which are more aggressive than the guidelines from the American Heart Association. They have the more or less similar definition of the high-risk patients, although there are some differences there. The European Society of Cardiology includes more patients into this category, whereas the American Heart Association has fewer patients in the very high-risk group. Almost all our patients are very high-risk group because they have had an event and they have atherosclerosis. The American Heart Association is less aggressive. It has less than 1.8 millimole or 1.7, I think, reduction in the LDL. But again, this is on the discretion of the cardiologist, and many risk factors need to be considered at the same time. If the patient has multiple risk factors there or a history, then we should be more aggressive. If the patient is a low-risk patient, then perhaps we can be less aggressive in that, yeah.
Thank you.
You're welcome. So the last thing to mention about smoking cessation is that patients who stop smoking, they tend to gain some weight in the first 3 months to 1 year. So the goal of the dietitian and the team in general is to help them maintain their weight. Ideally, they should lose if they are overweight or obese, but this is very difficult when they stop smoking. So the main goal is to maintain the weight, at least not to gain more weight. Psychosocial management. So heart disease is a disease of the heart, but as we know, the heart is not just a biological organ. It's an organ that affects all our lives. So there are several significant psychosocial risk factors there. So we have depression, we have anxiety, we have low social support. Many people, for example, are bachelors here in Qatar. We have social isolation. Some people are not social, maybe they work a lot. We have many laborers who are working a lot, so they're not very social at all. And when you are not social, you have a higher risk of heart disease. People with low socioeconomic status, excuse me, as I mentioned, we have some very poor people coming to the heart hospital. Cognitive impairment, this interferes with the medication adherence and all the adherence to the rehabilitation regime. Anger and hostility, this is of course very bad. It stimulates the sympathetic system. It causes high blood pressure. It causes arrhythmias, etc. Post-traumatic stress, sexual dysfunction is causing stress, all these things. If we have any of these things, but most of the times we have a combination of these things, we should educate the patients about their health, what to expect about their health, about their emotional well-being. We should provide exercise regimes because exercise reduces many of these symptoms. Psychotherapy, if needed. We have our excellent occupational therapists and psychologists in the corporations, in the Harvard Medical Corporation, who are providing these services. And if the patient really has clinical symptoms of depression, anxiety, or hostility, we refer these patients to a psychiatrist, because these conditions are important risk factors for prognosis of the heart disease. So if you have depression, then you have a much worse prognosis in heart disease than if you don't have depression, along with all these things that you have.
Okay, so Dr. Ted, so
Yeah.
it means that you do, let's say, different assessment of depression at different, I mean, assessment of depression at different points, right? And the initial assessment maybe in the mid of the exercise program.
Exactly, Muna.
Okay.
Before the patient is enrolled in the program, we do the initial assessment, as I mentioned. It has many components there. One of the components of the initial assessment is the screening. The screening for depression and for anxiety. We have these two, and quality of life. We have these three scales. The screening for depression is done in the heart hospital with the cardiac depression scale, which is a scale that is specifically designed for patients with heart disease. We also translated the scale in Arabic to offer it, the scale, to patients who cannot speak English. And this is an official translation with a publication there. So we're very happy to do that, and very happy to offer it to Arab-speaking patients, not only in Qatar, but all the Arab world, because it's very important to measure these things initially. Then we reassess these symptoms, because patients come for exercise 3 times per week. So we see them very often. Their mental and emotional well-being changes. So the nurses or the physiotherapists mention these things every time. Maybe the patient is more stressed this week or less stressed. So we need to reassess their stress levels or depression levels. And of course, at the end of the rehabilitation, we do again the final assessment, which includes all these assessments, including depression, anxiety, and quality of life.
Okay, and let's say if you had one of your patients who had like depression upon screening and refused to see the psychiatric. So does this classify the patient as high risk?
Yeah. Well, the cutoff score, we have a cutoff score in the scale, the cardiac depression scale is 100. If the patient scores more than 100, then we have a discussion with the patient. Our occupational therapists, they have a discussion with the patients. They tell them that we see that some symptoms of depression are elevated. Would you like to discuss this more with an expert or a specialist? We don't mention the word psychiatrist because it has a taboo, as you know, it carries a burden.
Yes.
Some patients accept, of course, others they don't accept. If they don't accept, we counsel the patients as much as we can. These patients are automatically allocated to the high risk of one component. So if they are intermediate or high risk of the other component, the total risk is high. If the other component is low, the total risk is intermediate. So we need to, so depression is very important. It affects the patient adherence to exercise. The patients don't come for exercise because they are depressed. They don't take their medications because they are depressed. You know, this is very important, and we check it several times throughout each patient's journey with us.
Okay, thank you.
You're welcome. So we go to reach the last core components of cardiac rehabilitation, the physical activity counseling. I put these elderly people there because I want to share with you one of my experiences in the UK when I studied there for a year. I was watching all these elderly people on the streets every day, jogging, cycling, people with white hair, people more than 65, 70, even more years old, older than me, and they were just going out there to jog regularly. They were overturning me when I tried to jog. I was much less fit than them. I wish we had this kind of mentality here in Qatar, if not outside the streets, in gyms, but unfortunately we don't have it. and we should aim to promote regular physical activity to everyone, including the elderly population. This is in every guideline for physical activity that you can see in the world. They say that we should engage ourselves in at least 150 minutes per week of moderate aerobic physical activity. Moderate means that it should make our heart beat faster. It should not be easy, but at the same time, it would not make us breathless. If we want to become a little bit breathless, we can reduce the time to 75 minutes per week. This time we do vigorous aerobic training. If we do more, it's fine. There's no problem that we achieve even more. We should also include twice per week resistance training in large muscle bodies of our body. We should always have in mind that sedentary lifestyle is a strong risk factor, very strong risk factor. It reduces cardiorespiratory fitness, which is a significant and independent predictor of mortality. And for people who are maybe not at all active physically, we should tell them that even if they increase their physical activity just a little bit, this will cause some benefit to them. So even if they exercise or go for a brisk walking for 10 minutes per day, this will add to them. And then they can build up on that 10 minutes for 1 week, maybe 15 minutes for the next week or next month. The importance is consistency. We cannot expect from the patient to increase their physical activity immediately. We would like to increase it very, very gradually, but keep that pace consistently. How to do that? A good way to do that is to integrate this physical activity to their everyday life. That's why the physical activity should be compatible with hobbies. They should make them feel happy. They should have fun with it. They should include it in their happy hour. When they go out, maybe they can go and play some game, maybe some tennis, or they can jog a little bit with friends. Anything that makes them happy, everything that wants them to do this again. And of course, the physical activity should be safe and effective. Safe, it should be in case we have this talk test, because you cannot really measure and see your ECG exactly when you are doing your regular jogging outside. Not all patients, of course, they have the smartwatch to see the heart rate. So if you don't have any of these things, the advice is the talk test. We say that you should be able to maintain a discussion when you are doing your physical activity. So you should not go too high in order not to have any risk for any bad things to happen. But at the same time, it should be effective. So I like to say to my patients that they should maintain a discussion, but they should not be able to sing. Because if you're able to sing, it means that you're not doing it hard enough. So not singing, but talking is good. It's safe and effective. This is an easy way to prescribe roughly, of course, roughly the exercise intensity for our patients. Going to exercise training, I will not take much time in that because this is a huge chapter in cardiac rehabilitation. Exercise is perhaps the most important core component of cardiac rehabilitation. That's why it is widely known as exercise-based cardiac rehabilitation. We usually have group exercise groups, as you can see here in this group, and we have them in the heart hospital. Again, the frequency should be at least 3 times per week, which adds to more than 150 minutes per week. The intensity should be moderate, as I said before, and we have several ways to prescribe the intensity. We can prescribe the intensity based on the VO2 peak, which is the maximal oxygen uptake, which we can see. We can determine that from a symptom-limited exercise test with gas exchange analyzer, which is called cardiopulmonary exercise test, which is, by the way, the golden standard in the assessment of the patients, and it is, as we see, recommended for the patients after COVID. If we don't have a cardiopulmonary exercise test, we can have a cycloergometer exercise test from which we can determine the maximum workload, which is the maximum workload here. And then of the test, we can see also the maximum heart rate, which is the maximum heart rate real during the test, not the theoretical one. The theoretical one has variation according to each patient, so we should determine the real actual maximum heart rate. And we can determine the exercise training zone here based on this or the heart rate reserve. The METs are the metabolic equivalents of energy. We can have 4 to 6 METs. And if we don't have any of these things, we can just have the Borg scale from 6 to 20. If you're familiar with it, 6 is zero exertion at all. It's like watching TV on your couch. And 20 is the maximal exertion that you can imagine, like being chased by a lion. So we should aim to an exertion from 12 to 14, which is somewhat hard. This is the feeling of exertion, somewhat hard. The duration is from 20 minutes to 60 minutes. This depends, of course, on the risk and the condition of the patient. Frail patients, very high-risk patients that cannot tolerate 60 minutes should be exercised less. On the contrary, a low-risk patient who may already be doing some physical activity on their own, they can engage in 60 minutes of exercise session. And the type is aerobic every time. We should have aerobic exercise because it improves the cardiorespiratory fitness, which I already told you this is a strong and independent predictor of mortality. We should aim to have resistance trainings twice per week. Flexibility balance, this is mainly for the patients who are frail, perhaps in the elderly patients. We can add some balance or flexibility exercise there to prevent falls. And in patients with specifically heart failure, we may also consider including inspiratory muscle training to assist the patients in their breathing. So this is the exercise training, not much detail here. And then, of course, we have the final assessment, which we evaluate what we achieved with this program and the follow-up for the patient. We sit with the patient. We see the success or failure of each goal. The goals, of course, they should be agreed with every patient. They should be smart. Every patient should agree and comply with these goals. We can see how well we did at the end. Of course, not all the goals are met always. And if they're not met at that time, we should follow up the patient to try and meet this goal in the long term. If we met some goals, we can establish some new goals, short and long-term goals there. We should also have a report of our patient, which is there in our patient's file of what happened in the cardiac rehabilitation, what we did, what we achieved. And this report should be available to the patient's cardiologist for the future or the patient's GP if we are in other countries. So we should provide a report to the patient to keep it with them and show what they succeeded and what they did in cardiac rehabilitation. And last, we should aim to have registry, a cardiac rehabilitation registry. That's why we can make sure that we have high standards of quality. And we are starting to have a cardiac rehabilitation registry in Qatar this year. Last year, we are engaged in a research project with the Qatar University School of Public Health. And we have a project to create the Qatar Cardiac Rehabilitation Registry, and we have started that. Excuse me, it's a pilot project, but it's going very well, and I'm very happy for that.
Thank you, Dr. Ted. We have a question here regarding, let's say, patients who fail to reach a goal, or maybe patients who fail to improve in terms of the metabolic risk. Do you consider re-involving patients in the program, taking into consideration that you are the only cardiac rehab program here and the amount of patients you have also?
Do we involve? What's the question?
Yeah, do you re-invite patients who failed, for example? Yeah.
We wish we can re-invite patients, but it's very, very hard because we are the only program in the country, and we have already a long list of patients waiting to enroll. So at the moment, it's impossible for the patients to enroll at least in 1 or 2 years. Maybe after that, we can be more flexible, but we need to offer the program to patients who really need it for the first time.
Sure. Okay. Perfect. Thank you.
Yeah, thank you, Mona. So moving up to the outcome measures. What do we measure with in cardiac rehabilitation for you to have an idea? So we have the clinical indicators and the quality indicators. The clinical indicators is the improvement in functional capacity. Functional capacity is just another word for the fitness of the patient. Functional capacity increases with exercise. So we aim to improve the functional capacity at least 5%. These are the guidelines. In the heart hospital, we aim to improve it at least 10%. We aim to reduce weight more than 5%. The asterisk there is for patients who stopped smoking. And as I mentioned, these patients need to maintain weight. The quality of life needs to be improved more than 10%. Again, the anxiety and depression score to be improved more than 10%. The adherence medication needs to be improved so that more than 80% of the medication of the patient is adherent, for the patient to be adherent in that. Smoking cessation, more than 50% of the patients should stop smoking. These are the clinical indicators that we need to meet for the program to have some kind of success. More than half of our patients need to control their hypertension. As you can see there, it's not very easy to control these things. That's why the percentage is not 100%. We would like to be on 100%, but it's impossible. The patients with dyslipidemia, they need to control it, half of them at least. Again, with diabetes, half of them. And then we have the quality indicators, which is the referral from inpatient setting. At least 80% of the patients in the hospital should be referred to cardiac rehabilitation before being discharged. This is the inpatient referral. Here in Qatar, we're very happy to achieve almost 100% referral because most of our patients come from the heart hospital, which we control and we can refer them. Time to enrollment is the time between the generation of the referral until the patient is enrolled in the program. This should be less than 28 days, according to the European and the American guidelines. Unfortunately, we failed to meet this target in Qatar because, as I said, we have a long waiting list and we are the only program. But we are expanding and we aim to achieve this goal in the near future. The dropout rate should be less than 25%. Worldwide, we have a high dropout rate of the patients, more than 30%. There are many factors involved in dropouts, but if we manage to keep 1 in 4 patients dropping out, not more, then we would be happy. One other quality indicator that struck me was the initial assessment to be performed in more than 80% of the patients. This is striking to me. We perform initial assessment in every patient. Without the initial assessment, we cannot be certain of the risks of the patients that they carry. So at least here in Qatar, we assess the patient initially in any case. We will see in the world that this is not always happening, as we will see now, right now. So why do we do cardiac rehab? Only because we like it? No, because it reduces mortality, 13 to 53% reduction in all-cause mortality and 26% reduction in cardiovascular mortality. These are meta-analyses there. This is the highest quality of research, of evidence out there. That's why we have the recommendations, as I show you, class 1 level A. And we also have reduction in hospital readmissions, 18% reductions in patients with coronary heart disease, and even higher reduction in patients with heart failure. Heart failure are patients who come to the hospital very often, so cardiac rehabilitation is a very cost-effective service for them. There are many other benefits, of course, but I want to tire you. One thing that I want you to remember is that patients live longer and they come to the hospital less often with cardiac rehabilitation. So we were happy about doing all these things, and then this thing happened. COVID came. I'm sure you are familiar with this early map that we're used to see, these red cycles. It's happening here, it's there, it's more, etc. So it was a chaos at the beginning. It hit the whole world. It hit Qatar as well. So I'm going to talk about the cardiac rehabilitation in the world and what happened there. And I'm only going to mention what happened in the first wave, which is the initial strike of the virus, which is the April of 2020, more or less on that. So during that time, from April to June 2020, around 3/4 of cardiac rehabilitation programs in the world were suspended. They stopped working. 3 out of 4 cardiac rehab programs stopped working entirely. The 1 out of 4 that continued working had these problems there. They either ceased to enroll new patients, they reduced the components of cardiac rehabilitation, as you remember, the core components that I showed you. They changed the mode of delivery, which means that they offered some core components from the phone or from video. They shortened the program duration. So ideally, the program should be 3 months, at least 3 months for every patient. But the COVID unavoidably made us reduce the program duration because there was no staff there, as you will see, or the combination of all the above. So you can really appreciate the damage that we received from COVID. In Canada, where research is quite extensive in cardiac rehabilitation, in the whole country, almost half of cardiac rehabilitation staff were redeployed to other facilities, to COVID facilities, and the remaining staff had less time-efficient one-to-one models of remote care. As I told you, if you remember, we have group exercise session, so there is one physiotherapist or exercise physiologist with 1 or 2 nurses and perhaps 5 to 10 patients there at the same time. In Canada, this didn't happen, so they have one-to-one session, which is not cost effective, of course, and it's not time efficient either. So as you can understand, the cost of the CR programs exceeded the revenues in many cases, and this was another burden to the system at the same time, the cost. What was the impact on the staff of cardiac rehabilitation? Severe. Again, this same period, there was a severe psychosocial and economic impact on the cardiac rehabilitation staff. So the staff were anxious. I remember my staff, our colleagues in the heart hospital, they didn't know when they're going to be redeployed or if. They didn't know exactly how to treat these patients at the first days. The protocols were not clear in the first days, if you remember. They were afraid of exposing themselves and their families. People have families, they're not alone, they have children at home, they have husband, wife, parents who are were older than them and of course more susceptible to the disease. So they were afraid of exposing them, the disease. Many of our staff, they just isolated themselves. This is not only our staff, also in the world, but I'm talking from experience in our department. So they felt lonely, problems in sleeping at night, stress due to higher workloads. Many of our staff, they had to work overtime, of course, to cover the caseloads. In the world, the staff needed to work because they were afraid of losing their job, despite the risk that they perceived that they had from the virus. So they were afraid of losing their jobs, but they also afraid of catching the virus, but they didn't have a choice, they had to work. This is striking to me. In the literature, it's mentioned that at least in 20% of cases, the sick leave was not paid in staff who were sick. This didn't happen here in Qatar, of course, but around the world. And also one on 5 members of staff was permanently or temporarily laid off or had their salary reduced. Alhamdulillah, this didn't happen here in Qatar. On the contrary, some staff got some bonuses also because they deserve it from these huge hours that they fought during this COVID period. So what happened to the patients? So the patients also suffered a lot. because of COVID. Again, the same period, more than 75% of cardiac rehab patients, current patients already enrolled in the program, and prospective patients who are eligible to enroll, were deprived from most of their care. As you saw, the programs, either they stopped entirely or they reduced the components that they have. You can imagine the consequences of these things on mortality, readmission, and quality of life. I mentioned before the benefit of cardiac rehabilitation on mortality, readmissions. So if these patients were deprived from this service, you can deduce that the mortality and readmission risk increased for these patients. And patients who were more vulnerable, patients, for example, which are in high risk, who are older, for example, or they have other comorbidities, or they are cognitively impaired, they were affected even more because they could not even pick up the phone or have a video call for the patient as consistently as a younger patient, perhaps, or a patient who is not cognitively impaired. So even these populations who are even more vulnerable, they became even more deprived from cardiac rehab and more risk of catching the virus, of course. One of the problems that the patients had is about their diet. Their healthy diet was affected because they had concerns on going to the grocery store, as you can imagine, due to the social isolation and the laws that were implemented in many countries. Patients, everyone in the country should stay at home for many days. So some patients, they didn't have the luxury to go and have healthy choices in their groceries. So the diet was affected. Mental well-being was affected. Of course, everyone was scared, was anxious, didn't know what to do. This causes problems, of course. Participation in cardiac rehab was affected. I remember even if we had some patients invited, many of them just didn't come because they were afraid. People were afraid to go to the hospital in general, not only for cardiac rehab, because they were afraid of the virus. And even in patients who were prescribed to do home-based exercise, their adherence was affected as well because of the whole situation. People were not adhering in any kind of treatment or rehabilitation. And if you have elderly patients, you can imagine that their frailty levels deteriorated because they were not exercising. They were not physically active at all. They're just staying at home, sitting or lying on the bed. So this is very, very bad. It's a sedentary way of living, and it affects all aspects of their health. So when this happened, there are many recommendations, starting to have many recommendations from organizations in the world. So the European Society of Cardiology started very early to give some guidelines. I'm not going to read them all to you. I'm just going to show you all here, just to understand. This is copy and paste from the guidelines. This is for you to show that these recommendations are very, very general. They don't have anything specific. For example, detect and fight fake news. Okay, we know that. Deliver as much CR as possible under the given circumstances. Be prepared to handle COVID-19 patients. People at that time didn't know what to do because it was a new thing, a new threat, and people didn't know exactly how to cope with it. So these guidelines are very general, and I'm not sure how helpful they were at that time. Later on, we had the Netherlands Society of Cardiology in July. This was a little bit more specific. It said to concentrate on main core components, the main and more important core components of cardiac rehabilitation, which is lifestyle risk management, psychosocial support, medical advice, and education. Okay, we should replace face-to-face sessions by remote assessment and monitoring and guiding. How can you remote assess a patient? Can the cardiologist assess the patient remotely in a sufficient way? Can they auscultate the patient? Not really, but I guess if you have the option of doing nothing, doing something is perhaps better. This is open to discussion, of course. Perform patient assessment and risk stratification with an exercise test whenever possible. So if not possible, use other tools to assess the cardiovascular risk and physical fitness. Other tools may be questionnaires only, just patient-reported questionnaires. And the RPE should be less than 12, so the exercise should be light, moderate to light. In complex, these are my brackets, in complex patients without exercise test. So for COVID-19 positive patients, we postpone the programs. Okay, this is of course logical. So the question is, if we do exercise with low intensity in a patient, which is mainly flexibility, coordination, and muscle strength, is it sufficient to invoke cardiovascular adaptations? Is it sufficient enough for the patient to improve the cardiovascular health? I'm not sure about that. That's why we do the initial assessment to provide the sufficient effective exercise intensity for the patient. So the the Cardiac Society of Australia and New Zealand, they also put up some guidelines there. There was a huge problem in Australia with patients staying at home. There were very big lockdowns there. So the recommendation was trying to promote the services to continue there to exist. So we also should take advantage of telehealth formats to retain e-health strategies after the pandemic. Okay, that's fine. How about during the pandemic? One thing that is mentioned there that struck me is that they say it has never been more important to avoid undertreatment of patients. You can imagine the undertreatment of patients that happened. Patients did not go to the hospital, they were afraid. They did not go to cardiac rehab, they were just afraid. Include psychosocial intervention in cardiac rehabilitation and evaluate the efficacy and cost effectiveness of new processes. Again, no mention of exercise testing or exercise prescription. Then we have two reviews that to me, they were not extremely helpful either. So one review in March 2021 says exercise is well suited. Okay, we know that. And 6-minute walk test as a tool to assess functional capacity. And the other one was later last year, which says that we should have an individualized approach on psychological symptoms, cardiac risk evaluation, and core components. We should replace face-to-face meeting with remote guidance. This is very nice, and we're doing that. We should conduct a patient evaluation by exercising as much as feasible. This is a review. And then we should use a variety of tools to evaluate cardiorespiratory fitness, again with questionnaires, if applicable. So my questions are, is the 6-minute walk test sufficient for risk stratification, exercise prescription? No, it's not, unfortunately. It's the last choice. If we cannot do a symptom-limited exercise test, it's the last choice, but we cannot conclude many things from a 6-minute walk test. Of course, if there's nothing else available, we should do it. And regarding the second recommendation is as much as feasible, clear and consistent assessment of functional capacity. No, of course not. It's not consistent. But again, perhaps if you don't have any other choice, you can do as much as you can regarding the assessment of functional capacity. One recommendation that is worth mentioning, finally, is the Delphi consensus for 28 experts from the European Association of Preventive Cardiology. Finally, there's a paper there that you can read from 28 experts. They took their opinions on 150 statements about cardiac rehab. Amazingly enough, they only reached consensus in 39% of the statements. Imagine these are 28 experts for cardiac rehab, but only 39% agreement. So they concluded that core components of cardiac rehab should remain the same. This is the consensus that I put here. So what we had should continue to have. Education on COVID-19 should be added as a new core component. Initial assessment should include frailty assessment and cardiopulmonary exercise testing. So as you can see here, we have a symptom-limited exercise test for every patient, cardiopulmonary exercise testing. It's not easy to do it for every patient. We do it in the heart hospital, but it's time-consuming and it needs staff. Sorry, Muna, do you want to say something?
Oh, it's okay.
Okay, sorry.
Yeah.
So this is a recommendation from the European Society of Cardiology branch. And according to this, we should have a symptom-limited exercise test in every patient. And of course, we should encourage remote activities, and we should integrate them or fully replace them, the routing operation, with remote operation like phone consultations and video consultations. This is good. Finally, we have some guidance. It's not the perfect guidance because many of these things are not clear yet, but at least the safety of the patient is paramount here. And this is what we have always been doing in the heart hospital in Qatar. So this is our gym here in Qatar Rehabilitation Institute. This is how empty it was. I show it to show the emptiness of our gym. So during all 3 waves, our services were affected. We have 3 waves here in Qatar, from complete suspension in the first wave to partial suspension in the second and third wave. I will only talk about the first wave here. These suspensions were due to countrywide restrictions in presential outpatient services. So it was not only to cardiac rehabilitation, it was in every outpatient service. So on the 16th of March 2020, all our services were suspended entirely. We stopped doing anything. More than half of our staff were redeployed in COVID-19 facilities. All enrolled patients were put on hold. All our patients stopped coming to the heart hospital. They stopped coming to QRI. They stopped doing anything. So you can imagine the impact on this restriction to the patients, because patients with heart disease are already in high risk. They have a high risk of complications that may include death if they catch the virus, if they're infected with COVID-19. So imagine these patients are an already high risk group, and they are also deprived of a service that improves their health. So what we had in mind is that we should continue our service as much as we can, but the safety of the patients should be our paramount concern. And then we should have our patients who are already enrolled enjoy as many services as possible, because these patients have already been assessed. We know the risk status. They should enjoy as much as possible cardiac rehabilitation. So what we did is we established video and telephone calls in the core components that could be provided remotely, like the dietary consultation, for example, or the medication adherence by the pharmacist, or the physical activity counseling by our physical therapists and exercise physiologists, or the smoking cessation counseling by occupational therapists. Then we created some short videos on physical activity and exercise, which were posted in the HMC website. I didn't include a video here because it's 10 minutes long, so it will take a lot of time, but it is available in the social media of the corporation for you to see them. And then we implemented the virtual exercise sessions, counseling sessions, and education clinics on July. Here you can see one of our staff. He's a physiotherapist, specialist, and one of our nurses. They are conducting a remote virtual exercise clinic. You can see that there is a camera on the top of the screen here, a small camera, and our physiotherapist is visible to our patients. Our patients are in their house here, 3 patients in the group, and they're following the instructions of the exercise from our staff in their houses. Of course, for this to happen, we needed to collaborate with Ministry of Public Health to be able to use an application that it is valid and approved for healthcare services. And also the patient's risk should have been evaluated by the cardiologist in our team for them to be safe to exercise at home and have some ECG monitoring there while doing exercise. This is what our nurse is monitoring here in the laptop. She's monitoring the ECG strip for these patients where they're doing exercise at home. So patients' privacy during group exercise sessions was another issue. That's why we managed to have a one-way communication. The patients could not hear each other or see each other, but we could hear and see them. And we established a new protocol on the
I think Dr. Ted has issue with the connection.
When the patients came to the hospital, we had strict infection control measures. We have social distancing. We reduced the group number of patients from 8 to 4 because the patients need to be in distance from each other. The patients did not pass from one station to the next. The patients stayed on their own territory, on their own area. They did not mix areas with the patients. Of course, the staff, they wore the necessary PPE, and we have a HEPA filter machine running during the exercise session. So this is what happened there, and this is what we continue doing it here. So what happens now, even today as we're talking, is that patients undergo initial assessment at the hospital, which includes a symptom-limited exercise test. Then, if they are eligible, they are enrolled in the program. Then they attend at least 3 hospital-based exercise sessions. Most of them, they attend more than 3, but at least 3. And then they are determined if they are eligible to transfer to home-based exercise session through our weekly team conferences. The cardiologist evaluates the patients and their feedback from each of the disciplines and decides if these patients are eligible to transfer to home-based program. If they are transferred with appropriate level of monitoring. The patients may go, for example, in their house with an ECG monitoring device, which transmits the ECG signal from their house to our hospital live during the exercise session, so we can monitor them. And we have ordered a new and bigger system with remote ECG monitoring now, and we're expecting to expand in this service. So patients have a choice of hospital-based or telecounseling and education throughout the program. If they like, they can receive their counseling through phone or video, or they can come to the hospital. And then when the program is complete, all the patients undergo a final assessment at the hospital. They need to come to the hospital, and then we need also to do a symptom-limited exercise test. So a few observations of the new normal. Regarding patient safety, all patients undergo symptom-limited exercise test prior to enrollment. This happened before, and this continues to happen here. During the pandemic and even after the pandemic, the patient safety is paramount for us. The level of monitoring should be reevaluated frequently, so we reassess the patient's level of monitoring. If they are on home-based program, we should aim to have seamless connections. If we don't have, then we either stop the sessions or we reduce the intensity to very, very light. How about patient convenience? Is it convenient? Of course, because they have more options. The patients can choose now to come to the hospital or do the exercise at home. Is it effective? I haven't done a research. We haven't done a statistical test to compare the clinical indicators prior to after COVID. But in my I have done some comparisons, and I don't think there's much difference there. So it seems to have the same effectiveness as it had before. The program capacity is increased, of course, because we added the virtual exercise clinics. The virtual exercise clinics require less space. You saw a small room there with the exercise physiologist. There's no need to have a huge gym to conduct the exercise session. Patients are doing it at home. And also, perhaps we can accommodate more patients per session, per virtual exercise session, up to a specific limit. Of course, we cannot have too many patients because we need to monitor. So if we take all these things into consideration, we can say that the program is even more cost-effective now. But we should always have in mind that virtual exercise clinics are not for everyone. High-risk patients and very high-risk patients cannot do exercise from home. They are not eligible to go home and exercise alone, even if they have someone there who is always able to call the ambulance if something happens. High-risk patients should be monitored closely and should do exercise at the hospital. So the virtual clinics are very good for low-risk patients and for some intermediate-risk patients, but for most high-risk patients, they're not available. We should have them at the hospital. I'm closing the presentation with this image again to ask if this is the future in cardiac rehabilitation. If we have virtual exercise session and we have huge monitoring stations with the patient ECGs while they're exercising at home, we have very small rooms. Each room can have one physiotherapist and perhaps 5 to 10 patients there with a nurse monitoring them. This is probably highly cost effective. We perhaps can do some more research there and see if this is the new normal. But we are also offering this hybrid program, as I told you, together with hospital-based exercise session. But I think, if you want my opinion, this should be the future because it's very convenient. And as long as the initial assessment is thorough for the patients and the risk is very well stratified, then I don't see any risk there moving the patients to their houses if the risk is justifiable, of course. So these are my references, and this is our team in the heart hospital. Before COVID, this photo is before COVID. There's no mask there, as you can see. You can only see smiles. Inshallah, we will have these smiles again soon in Qatar for everyone. We'll get rid of the masks and of this virus. Thank you very much for your attention.
Thank you so much, Dr. Ted, for such a comprehensive presentation. It's quite impressive to see such very comprehensive program that has multidisciplinary teams where you provide many actually interventions. And I think maybe it's rare to see such a program. So I would like to thank you so much for your great effort, and we'll extend our thanks to the team. And here we have a thanking message from Dr. Karam Adawi. She thanks Dr. Ted for this interesting and informative presentation. Indeed, this cardiac rehab program is one of the best in the region due to the dedication of the cardiac rehab staff who work continuously to improve the quality of services delivered, including the development of Qatar cardiac rehab registry, and thanks also to the cardiac rehab staff and Dr. Muhammad Al-Hashimi.
We are very happy to collaborate with Dr. Karam. She is a professor in Qatar University, and we are collaborating in several aspects. And currently with the cardiac rehabilitation registry, as I mentioned, it's a collaboration between us, and we're very happy to have her. She's excellent.
Yeah, we wish you all the best. But Dr. Ted, I have 2 questions to be addressed.
Yes.
Do you exclude any patients from your program? They are not eligible, for example, to be enrolled?
Yes. Yes, that's why the initial assessment is very important. When the patient comes, they should undergo the initial assessment, which is thorough. So some of our patients are not eligible. For example, they may have some existing ischemia that needs to be investigated. Some pending lesions in the coronary arteries that needs to be investigated. Or the patients may not be eligible because they may have musculoskeletal problems that may prevent them from joining a class or undergoing a symptom-limited exercise test. So some patients are not eligible. Maybe some patients may have symptoms at rest. So breathlessness, for example, at rest, and engaging them in a program might be more risky than beneficial. So yeah, some patients are not eligible.
Very excluded. And with the COVID pandemic, I'm not sure if you had the chance to involve patients post-COVID. And did you observe that these patients, they were at higher risk, let's say, even if they have low risk factors, but they are post-COVID patients, where these patients are at high risk for complications during exercise? Did you notice any of
That's
these?
a very good question, Muna. We haven't noticed that. We don't have any extra, if you want, any extra exam, any extra test for post-COVID patients. We just require them to be COVID-free.
Okay.
So yeah, this is a very good question and a very good research question, perhaps, to see if post-COVID patients who are enrolled have differences compared to patients who have not passed COVID.
Yeah.
So we do exactly the same initial assessment for every patient,
Mm-hmm.
and we just risk stratify the patients. But it's a very good question, and perhaps we can do that.
Yeah.
Thank
Yeah,
you.
you might consider, yeah, because there are some complications of COVID, so maybe this can affect the outcome during exercise sessions or at the end of the program. And it's interesting actually to see how we were able to shift the program to a virtual program. And like I wanted to ask you if it's possible to have this virtual sessions later on, but as you said, I think it needs quite like management, a lot of resources.
Well, the virtual sessions, they do not need
Resources.
many facilities or much
Okay.
infrastructure to be done. You just
Okay.
need the monitoring equipment to have,
Okay.
and you just need some space and staff to do it. And the eligible patients can participate. So this is highly cost effective.
Okay. Excellent.
The issue here, as I mentioned, is that the thorough assessment should be done at the beginning. The initial
Yeah.
assessment should be done, and the risks should be clear for these patients.
Yeah.
Because you're not seeing them, you're not there. They're in their house.
Right. Exactly. Yeah.
But I
So
think
you
this
have,
is the future. I mean, if we do
yes.
proper initial assessment, I think this is the future in cardiac rehab now.
So to ensure the safety of these patients, as you said, you have to do like the initial assessment, and they should be classified as low risk patients, and they will have the monitor with them at home.
Not necessarily low risk, can be intermediate risk. Very few high risk patients can also be eligible for exercising at home. And we also have, as I said, the ECG monitoring that we can give it to the patient. To the house, but some patients, after a while, if they are even low risk, they don't even need this ECG monitoring. They can do exercise at home, and this will also gradually resemble their everyday activities in life, because the program will stop at some point, and this patient needs to do some exercise alone without ECG monitoring.
Yeah,
So we try to progress and move on to the normal life that this patient have, at least in the final sessions, whenever eligible.
Yeah, exactly. Yeah, so I think this was a very interesting talk about cardiac rehab and how we were able actually to shift to virtual and to adapt to the situation with the pandemic. I would like to thank you so much, Dr. Ted, for your presentation today, and would like to thank our audience. And I would appreciate if you can do the post evaluation. We will send you the link after the session. And again, thank you so much all for your time. And thank you so much, Ted, again. Thank you so much.
Thank you. Thank you, Muna.
Thank you. Thank you.